Hello, you're here again. So join me as I read Schwartz Principles of Surgery, 11th edition, Chapter 32, Gallbladder and Extrahepatic Biliary System, specifically Diagnostic Studies. You will find this on page 1398 up to page 1401. Okay, let's start. Diagnostic Studies. A variety of diagnostic modalities are available for the patient with suspected disease of the gallbladder or bile ducts. In 1924, the diagnosis of gallstones was revolutionized by the introduction of oral cholecystography by Graham and Cole. For decades, it was mainstay of investigation for gallstones. It involved oral administration of radio-opaque compound that is absorbed, excreted by the liver, and passed into the gallbladder. Stones are noted on a film as filling defects in a visualized, pacified gallbladder. In the latter half of the 20th century, biliary imaging improved dramatically with the development of hepatobiliary scintigraphy, the radionuclide scanning, as well as transhepatic and endoscopic retrograde cholangiography, or ERCP, which allowed for more detailed imaging of the biliary tree. Later, ultrasonography, computed tomography, and magnetic resonance imaging would further improve the ability to image the biliary tract. So first, diagnostic studies here is the blood tests. When patients with suspected diseases of the gallbladder or extrahepatic biliary tree are evaluated, a complete blood count and liver function tests are routinely requested. An elevated white blood cell or WBC count may indicate or raise suspicion of acute cholecystitis or infection within the gallbladder. If associated with an elevation of bilirubin, alkaline phosphatase, and transaminases, cholangitis or infection within the biliary tree should be suspected. Cholestasis, an obstruction to bile flow, is generally characterized by the elevation of conjugated bilirubin and a rise in alkaline phosphatase, but it may have no transaminitis. Such pattern may suggest choledocholithiasis or stones in the common bile duct, or an obstructing lesion such as stricture or cholangiocarcinoma. In patients with simple symptomatic cholelithiasis, biliary colic, or chronic cholecystitis, a chronic inflammatory state of the gallbladder without infection, blood test will often be normal. Next diagnostic test is the transabdominal ultrasonography. Transabdominal ultrasound is the initial investigation of any patient suspected to have disease of the biliary tree. It is non-invasive, painless, does not submit the patient to radiation, and can be performed on critically ill patients. Adjacent organs can also frequently be examined at the same time. However, its reliability and interpretation are dependent upon the skills and experience of the operator. In addition, obese patients, patients with ascites, and patients with distended bowel may be difficult to examine with ultrasound as the quality of images obtained in these situations can be poor. Ultrasound will show stones in the gallbladder with sensitivity and a specificity of greater than 90%, and can also reliably detect other pathologies of the biliary tree. Stones are acoustically dense and reflect the ultrasound waves back to the ultrasonic transducer. Because stones block the passage of sound waves, so the region behind them, they also produce an acoustic shadow. Stones move with changes in position. Polyps, on the other hand, may be calcified and reflect shadows, but they do not move with a change in the posture. Some stones form a layer in the gallbladder, others form a sediment or sludge. A thickened gallbladder wall, pericholecystic fluid, and local tenderness with direct pressure by ultrasound probe over the fundus of the gallbladder show sonographic Morphy's sign, may indicate acute cholecystitis. When a stone obstructs the neck of the gallbladder may become very large but thin-walled. A contracted, thick-walled gallbladder can be indicative of chronic cholecystitis. Extrahepatic bile ducts are also well visualized by transabdominal ultrasound, with the exception of retroduodenal portion. Dilation of the biliary tree in a patient with jaundice suggests an extrahepatic obstruction as the cause of the jaundice. Frequently, the site and sometimes the cause of obstruction can be determined by ultrasound. Small stones in the common bile duct frequently get lodged at the distal end of it, behind the duodenum, and are therefore difficult to detect. A dilated common bile duct on ultrasound, small stones in the gallbladder, and a classical clinical presentation allows one to assume that a stone or stones are causing the obstruction. Periampullary tumors can be difficult to diagnose on ultrasound, but above the retroduodenal portion, the level of obstruction and the cause may be visualized quite well. Ultrasound can also be helpful in evaluating tumor invasion and flow in the portal vein, an important guideline for resectability of periampullary tumors. Next, for diagnostic studies, is the computed tomography. Abdominal CT scans are frequently used in the workup of undifferentiated abdominal pain and thus often diagnose gallbladder disease. CT scanning is inferior to ultrasonography in diagnosing gallstones but is similar in sensitivity for acute cholecystitis. The major application of CT scan, however, is to define the course and status of the extrahepatic biliary tree and adjacent structures, and to evaluate for alternate causes of patients' clinical presentation. CT is also the initial test of choice in evaluating in patients with suspected malignancy of the gallbladder, the extrahepatic biliary system, or nearby organs such as head of the pancreas. Use of CT scan is an integral part of the differential diagnosis of obstructive jaundice of unknown origin. Next study is the hepatobiliary scintigraphy. Hepatobiliary scintigraphy, or the hepatobiliary immunodiacetic acid, or the HIDA scanning, is another option for non-invasive evaluation of the liver, gallbladder, bile ducts, and duodenum that provides both anatomic and functional information. 99M technetium labeled derivatives of immunodiacetic acid are injected intravenously, taken up by the Kupffer cells in the liver and excreted in the bile. Uptake by the liver is usually detected within 10 minutes, and the gallbladder, bile ducts, and duodenum are typically visualized within 60 minutes in fasting subjects. The primary use of biliary scintigraphy is in the diagnosis of acute cholecystitis, which appears as